your current position and field of interest. Could you please describe the group you lead, its facilities and technologies? What are the main objectives of the group, and what kind of research activities are currently ongoing? What are the perspectives for future research in the biomolecular field over the next years? And how might artificial intelligence impact research? What advances are expected, and how could they contribute to the development of new technologies and research approaches in this field? Professor Giuseppe Curigliano is the first. Giuseppe, please.
Good afternoon, first of all. My name is Giuseppe Curigliano. I am a professor of medical oncology at the University of Milano, and I lead the yearly drug development department at the European Institute of Oncology. My current field of interest is early drug development. You know, doing early drug development in 2023 means that usually you have to perform biopsies and liquid biopsies to any patient that will accept to participate to an early clinical phase trial, usually phase 1 or early phase 2. In this case, we perform biopsies and we perform also an extensive NGS, both on the liquid biopsy and on the solid tumors. The activity, of course, of my group is mainly to perform deep multi-omic analysis of patients that are enrolled in phase 1 trials. So it means specifically to have a multi-omic evaluation that can be potentially predictive of response or of progression to specific targeted agents. Actually, we are running something like 70 phase 1 trials on the same platform. And the main objective of my group, of course, are principally aimed to have a decision go, no go, respect to a specific agent. Our activity is both in collaboration with Big Pharma, but we have many also trials that are investigator-driven. And actually, the research activities we are currently performing are mainly 3. The first one is to better assess biomarkers predictive of response to immunocheckpoint inhibitors in early and metastatic breast cancer. The second one is to better assess minimal residual disease in patients that completed the neoadjuvant treatment. And in order to stratify the risk, we would like to perform an analysis with a liquid biopsy to better evaluate the clinical utility and the clinical validity of minimal residual disease in patients with early breast cancer. And finally, we are studying mechanism of DNA repair, assessing the role of homologous recombination deficiency in patients not BRCA mutant, but with high or low homologous recombination deficiency. So the perspective for future research in the biomolecular field of the next years, I believe they are exciting, because in my opinion, we are going to generate for any single patient an avatar with a multi-omic analysis. And our idea actually in my institution is to match clinical data with genomic data and radiomic data. So integration of imaging, clinical data, and biomolecular data in order to better assess biomarkers that are predictive of response or resistance to specific treatment. To do this, we are using platform of artificial intelligence, because the best way to integrate those data, of course, is to have external device and tools that will consent to you to integrate the data of pathology, of molecular biology, multi-omic analysis, and radiomic analysis. So in my opinion, in the future, we have a real-world patient, and we have on the other side an avatar of that patient that is an integration of all the data that you can match to better improve the outcome of cancer patients for whom we are taking care.
Giuseppe, you have also very good experience in the field of molecular tumor board.
Yes, of course, this is a parallel activity that we are conducting. You know, this is a clinical service, actually. The molecular tumor board in my institution can be research, but is mainly clinical service. So any patient that perform a multi-gene testing in our institution, an NGS with a large panel, if there is an alteration that is not so obvious, we do not discuss in the molecular tumor board patient with epidermal growth factor receptor mutations or mutations in which you have already a drug approved. We discuss those patients with complex NGS in order to, of course, allocate patients to treatments that are actually off-label, or to better give indication to clinicians on which treatment should be avoided because the NGS panel may predict the mechanism of resistance to that specific therapy. Our molecular tumor board is actually working in my institution since at least 4 years. We published the first data on European Journal of Cancer a few weeks ago, demonstrating that the decision that is taken in a molecular tumor board can really impact on the outcome of patients, improving both median progression-free survival and overall survival.